All right, good morning, everyone. Thanks for coming to our meeting today. Second meeting since we've had our little break for COVID. So we're all still excited to be able to meet in person, get to hang out a little bit afterwards, enjoy some refreshments, and get a lot of your questions answered, get some good information into your heads. It sounds like we have a lot of new people today, so thank you for joining us. New faces in the audience, and I think Bob said he handed out 10 newcomer packets. So, and yeah, we'd like to extend a special thank you to Sanford Burnham Prebys Medical Discovery Institute for letting us have this auditorium. We're certainly glad that they're letting us back in here. The principals of the organization are Bill Lewis, our president, who also does the newsletter summary, Jean Van Vliet, our director here and treasurer, Steve Pendergast, secretary and newsletter editor, Bill Manning, our director and videographer, myself, Aaron Lamb, and John Tassi, our webmaster. There's Bill Lewis right there. Yeah, thanks. And of course, there's you. We have well over 900 members, growing, of course, every month. And everyone is a volunteer. You can be as well. So many of you today are new to the group. Thanks for joining. If you can, before you leave today, please do fill out and hand in that cover sheet. Each of you will then get contacted early in the next week to discuss your personal situation. So either usually Jean or Bill gives you a call to see what questions you might have, see where you are in your diagnosis or treatment, and help you out. And for those of you that have not yet connected with somebody else with prostate cancer, it's really a reassuring conversation and very useful. So please do, I encourage you all to stay active in this group and get a lot of information from us, because there's really no other group like this that I've encountered, and really good supplement to what the info you get from your doctors. So let's do a little bit of a survey here. We'd like you to raise your hand if you are here for the first time. 2, 3, 4, 5, 6, 7, 8, 9. Excellent, yeah. Thank you for being here. And how many of you have been recently diagnosed? All right, excellent. Excellent. How many have had PCA for less than 1 year? All right, excellent. And from 1 to 4 years? All right, just a couple there. 5 to 10 years? Quite a few of us. 11 to 15 years? Again, a lot of people. And how about longer than that? Jean, how long have you? 20? Since 2004. 18 years, yes? And 21. Excellent. Was there somebody else here with their hand up for?
Yeah, just 16.
16. Excellent. Yeah, the takeaway from that, especially for you newcomers, is that this, and as you saw on that first slide, prostate cancer is 2 words. It's not a sentence. It's very likely that you're going to have a terrific long life ahead of you. It might be a little bit unsure of your situation right now, but I guarantee that there's somebody else in this room or in the organization that was exactly where you were. For them, it was a few years ago, and they're in a completely different place today. And it's nice to be able to, see other people's journey and go, oh, I was just like that person was 5 years ago, and that's the way they are today, and they're, enjoying life and doing perfectly well. As far as the treatment that everybody has had, who here is under active surveillance or has done active surveillance in the past? So there's quite a few of you. Oh, so active surveillance is, let's see, do you have it's
carefully with scans and so forth to make sure that nothing's wrong.
PSA levels.
Yeah, keeping track of PSA levels, typically following like a Mediterranean-style diet or a diet that helps to reduce PSA and prolong the need for more significant treatments. How about surgery? How many people here have had surgery? All right, quite a few. And how about radiation, either proton, X-ray, or brachy? Quite a few. It's a very popular treatment these days. How many people have had ADT or hormone therapy? Quite a few. Yep, very common as well too. How about chemotherapy? A few of us here still, chemotherapy. How about new treatments? Anything from focal HIFU laser to immunotherapy with Provenge, Xofigo, Pluvicto? How many of us here? All right, excellent. Yeah, it's quite there's certainly so many new treatments coming out to help out. It's a great time to be getting treatment for prostate cancer compared to decades ago. How many people are facing recurrence? Yeah, quite a few. And, one thing to remember about that is that, this is a little bit of an unfair sampling of people that have had prostate cancer. A lot of people in this room have recurrence, and they're here because they are trying to figure out what to do for their next treatment. A lot of people go on to either have a very low or undetectable PSA after treatment for years or decades, and those are not the people represented in this room. With our situations, we do have excellent prognoses typically. How about other types of treatment? How many have gone for psychotherapy, psychiatry therapy, mental therapy, life coaching, so forth? I certainly have, and for me, it was actually vital as a part of my treatment. Not only was my psychotherapist extremely useful just for really just giving me a sanity check on whether I was going through a proper process or checking the background of a doctor, but I was also, single at the time, questioning my own viability in life. From then on, I was 43 when I started my journey, even though I was detected at 39 and misdiagnosed. But it's not something that if you do shy away from therapy, I recommend giving it a second thought on choosing to go with it. Having guidance, professional guidance during this time in our lives is very important. How many have been on antidepressants? I certainly have. It's actually quite useful when you're on ADT and you have very low testosterone. You can become very depressed when that, both from the lack of energy that you encounter and just the change in hormone levels. How about procedures to address incontinence? Artificial sphincters and so forth. Incontinence is definitely one of the biggest side effects that we think about when it comes to any of these treatments. There are people in the group that have looked into these types of things and can provide advice. And how about anybody who's sought out sexual wellness treatment? We have obviously erectile dysfunction is also a very big concern, and it's probably the biggest concern that we don't like to talk about so much. But we're all going through some amount of issue with erectile dysfunction during treatment, and there are plenty of things to help with that. And myself, I'm also very happy to discuss any of those types of any of the things on the list here. Yes, hot flash is definitely a side effect of a lot of these treatments that we have to deal with. Yes, definitely give a lot of women a lot of sympathy for the hot flashes that they all have to go through, having gone through them myself. Now, how did you get here? How many saw the ad in the Union Tribune, either on a Sunday or another day? Did we run it this month? We've stopped. Okay, excellent. How about was referred by word of mouth from another patient? Oh, excellent. Referred by one of your medical professionals? All right. Who referred you? My primary care doctor at the time. Oh, excellent. Who was that, if you don't mind? Brown. Okay, okay. How about found us by way of a Google search? Yeah, okay, excellent. I think that was the first way I found it myself. How many people have seen the bumper stickers on the cars? You know, hopefully not just in the parking lot here, but hopefully we're getting quite a few out. And I do encourage you, there's some bumper stickers out here. Please do take one with you and help advertise. And we also have the trifold brochures that we've handed out. Anyone get to the group by way of that? Oh, excellent. Was that in a doctor's office, or where'd you find that? Excellent, excellent. And how many of us have a spouse that discovered us and drags you in here? Excellent, excellent. Plus ones are definitely welcome here, and yeah, very important part of our lives. Thank you for that. And how about found us any other way? Fred, how did you encounter us?
I don't remember.
Okay.
There was a local paper, number of years.
Local paper, another newspaper. All right, thanks. So our support to you comes in the way of our website, which hopefully all of you have seen. There's a wealth of information there, links to books, links to all of our newsletters, which you can get either by email or mail. I highly recommend reading those. They have a wealth of information in there, very up-to-date medical papers and so forth. There are also our monthly meetings, as today, third Saturday of every month, but not in December. So next month we'll have a little hiatus for the holidays, but we'll see you in January. We also have several hotlines. We have Jean and Bill. Their numbers are shown there, and you can also find all of this information on the website. You can get these numbers if you aren't able to jot them down right now. And we also have Sharon, who has offered to be a hotline respondee for women, family, and caregivers. As much as it's stressful for the patients to go through all of this, there's plenty of questions from our caregivers. And Sharon's been awesome to help answer questions there. We do need volunteers. We would like people to suggest and recruit new speakers for us and to share your experience. For those of you that have been a part of the roundtables where you've gotten to share your experience, I know Bob has, I have, a number of people in the audience have. These are extremely useful meetings that we have once or twice a year. And that's where you get to see, somebody's whole treatment history and go, that person is, very similar to where I am. And you can, it makes it a lot easier to see where you'll be in a few years. We are also looking for help in the way of a librarian who would be here to help set up before our Saturday meetings, bring a couple of boxes of books or DVDs of the prior meeting presentations and so forth. Those are very useful for checking out items to review. I know we have a lot of the PCRI conference DVDs that are extremely popular and stuff. So if you are interested in helping out with that, we would really appreciate adding a librarian to our roster. So please contact us through the website or the hotline number. So one thing we'd like to make clear is that we are a patient-focused experience we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals. And any sharing by any one of our group may not be a substitute for your medical counsel. And we do need your support. We are a 501c3 nonprofit organization. Donations are tax deductible. Bob, would you help me pass these through the audience? We don't have any medical or religious affiliations, and our largest costs are our website, advertising, and mailings. Please make a donation. You can do that either online via PayPal by sending us a check in the mail, or please, if you would, give a contribution today. We certainly do appreciate it. Now, I couldn't help but doing this, but we have a great meeting with Dr. Munt and his group of rad MDs. It's almost like a band name. I mean, they should go on tour. But Dr. Munt and the rad MDs, they will be here in January. Gene, do you know how many people will be here presenting that day?
At least 3. Just been promoted to
Right. And will Dr. Rossi this year? Excellent. Yeah, so we have a...
And a new man whose name he couldn't give me yet because it's not been announced.
Excellent. So the latest and greatest of UCSD and the California Proton Center. They will be joining us in January. For today, we have Dr. Mitchell Kamrava, a radiation oncology specialist from West Hollywood, and he will be talking about which one is the best, SBRT or brachytherapy. So, Mitch, come on up. Awesome. You can just either do this, or if you want to walk around, we've got laser pointer as well as this. Perfect. Forward and backward. And that's all I have to do.
Awesome. Thank you so much. That's mine. Yep. Just leave it here. Okay. Well, thank you guys so much for having me. I'm Mitch Kamrava. I'm a radiation oncologist at Cedars-Sinai in Los Angeles. Just a little bit of background about who I am, and I guess I'll do this as I have some of my disclosures. Always good to have an idea of some of the biases that your speaker may have. So just a little bit about my training. I did residency at the NCI and then did a fellowship in brachytherapy in 2010 at UCLA, and then stayed on staff in the brachytherapy division at UCLA from 2011 until 2016, and then was recruited over to Cedars-Sinai to help start their brachytherapy program, and have been at Cedars-Sinai since that time. So I'd share that only to say, so the ABS is the American Brachytherapy Society, so I do sit on the board of directors for the Brachytherapy Society, and the rest are not really so relevant. So I do come with some brachytherapy bias, but I'm going to try to share kind of a balanced perspective on SBRT versus brachytherapy for you guys. So here are kind of the goals of our discussion today, and if anyone's getting lost as we go, just raise your hand. We'll try to answer questions. This is really meant to be an education session for you guys, so happy to try to do the best I can to answer your questions. So we're going to try to just review the rationale and the different logistics of brachytherapy and SBRT. So SBRT is stereotactic body radiation therapy. So this is a type of external beam radiation therapy that's usually delivered, at least for right now, and typically just 5 treatments that are given every other day. So that's very different than kind of just our standard external beam, which is often given daily for 4 weeks or 5.5 weeks, and some people still get closer to 9 weeks, right? So that's a big difference going from, let's say, 9 weeks down to 1.5 weeks, right? And then we're going to talk a little bit after we are all on the same page about what are these 2 techniques and how are they actually done. We're going to spend a little bit of time talking about, are they actually similar in terms of PSA outcomes? That's kind of one thing to look at. And then what about quality of life? How does it impact patients either the same or differently? Okay. So just a little bit of background here just on prostate cancer. So it's the most commonly diagnosed cancer in men. These are recent statistics. So, it can be over 250,000 men, unfortunately, diagnosed with prostate cancer, kind of in the United States. And you can kind of see what the rest look like. So this is common. Either one of us will get it, or a family member, or brother, or father, or grandfather, a friend. So this is going to be common. It'll be unlikely that you're going to go through your lifetime and not know someone who had prostate cancer. But there's also good news, and I think this is a little bit what makes kind of dealing with prostate cancer a little bit complicated, because when patients are diagnosed, it gets confusing because some guys are just watching and doing active surveillance, and some guys are getting like surgery and radiation and hormones, and it's kind of confusing to be like, wait, do we all have the same thing, or kind of what's going on? And prostate cancer does present with different levels, if you will, of aggressiveness. The fortunate thing is that most men present with localized disease, as you can see, meaning that it's just in the prostate, hasn't gone to lymph nodes, hasn't gone to the bones or anywhere else. And if you look at your chance of being alive at 5 years after diagnosis, regardless of kind of whether you have disease just in the prostate with localized or regional, you've got a really, really high chance of doing really, really well. I mean, I like the comment that was made this morning that prostate cancer is just 2 words, it's not a sentence. And it's true. We have people in here who have had prostate cancer for over 15 years, over 20 years, right? So most men will do excellent kind of with treatment, and that's really important, I think, take-home message, okay? The other important take-home message from that is that it's really important to think about your quality of life after whatever treatment you choose to get, because you are very likely to be alive and experience whatever side effects may happen from your treatment. So I try to encourage patients to think about the long haul, like 5 years, 10 years from now, in terms of how you're going to feel and kind of what side effects, if you get them, will be acceptable kind of for you. Oops. So here's the problem in a nutshell that we're going to try to tackle. Okay, so this is a page from what's called the NCCN guidelines. The NCCN stands for the National Comprehensive Cancer Network, kind of here. So it's made up of experts in prostate cancer from across the United States. They meet each year to review like the best data that we have, and they try to come up with suggested pathways for what do we think is best, like in 2022 versus 2023. So it gets updated. Okay, so this is a page from basically just patients with favorable intermediate risk group prostate cancer. The reason that I picked this page is that this is the most common kind of group that patients are diagnosed in. So if I back up just for a second, prostate cancer is a little bit different than other cancers in how we discuss it. Most cancers we discuss like, well, what stage are you? I'm stage 1, I'm stage 2, I'm stage 4. But prostate cancer, we refer to risk groups. The risk groups run from very low to very high. What it's referring to is if you do a definitive treatment, let's say like surgery or radiation, which are the 2 most standard, the question is, what is the risk that if you do that treatment, that as you get followed, and the way that we would monitor things is a blood test and checking your PSA, what is the risk that your PSA would still go up after you got one of those treatments? Okay, so the low risk means you have a lower chance of that happening if you get definitive treatment, whereas if you're a high or very high risk patient, even if you get these treatments, there's a higher chance that your PSA could still rise after one of these treatments. So most men will kind of be in this favorable intermediate risk group, so that tends to be someone with a Gleason score of just 3+4 and usually like a lower PSA and no extension of the disease outside of the prostate. Okay, so here's the problem. The problem is if you're expected to live like more than 10 years, which is going to be the majority of people, here are the options: active surveillance, EBRT is external beam radiation therapy, or brachytherapy. So you can think of this arm as radiation. And then this arm down here is surgery. RP is radical prostatectomy. So what you can notice here is that the way these guidelines are written, they usually will put something like in parentheses category 1 if we know like for sure this is the best. We know this from like randomized trials. This is exactly what you should do. But if you notice on here that there is no like category 1, and that's because each of these are reasonable options. And I think that's where the challenge comes for men. They love coming in and they want me to say, this is the best, this is what you should do, this is what we know. And unfortunately, we can't really have that consult because each of these are viable options, okay? So when we start looking into a little bit like what are your options with radiation, it actually even gets more complicated. There's a lot of potential things that you could be offered. And this is just kind of one way of looking at it. There's external radiation, and that really doesn't include a discussion of photons, which is the most common kind of beam that comes out of the machines that we have, versus protons. You guys have a proton center close to you, and so that's like a very feasible option for many men, whereas that's not for people that live in cities where a proton center is far away. And then, like we touched on this, there's kind of standard fractionation given over 8 to 9 weeks, something called hypofractionation, usually given over 4 to 5, and then we're going to spend most of our time talking about SBRT, which is usually given just every other day over 5 treatments. And then we're going to talk about brachytherapy, and there are 2 types of brachytherapy. One is called low dose rate, where they're actual little seeds that are implanted into the prostate. We're not going to go into like the different types of seeds that could be put in. And then we're going to talk about HDR, which is high dose rate, which is more virtual seeds. But you can see that, depending on who you see, there's all sorts of other things that may be offered. The area that I think is kind of growing the most, kind of with urologists really being center stage, is different types of ablation. Honestly, every 6 months there's a new type of energy or something that's coming out that can ablate your prostate. I think the newest thing we've seen a number of men get is TULSA. And the other thing that we're not going to focus too much on, but we'll talk about, but there's a lot of discussion about focal therapy versus whole gland therapy. So you can see how this kind of starts like relatively simple up on the top, but then when you really start getting into it, there's a lot of side branches here of things that kind of go out. Yep. Meaning like you're just killing part of like that prostate tissue. So usually it's used mostly in reference to a focal therapy, meaning that it's standard to treat the whole prostate gland, even if your biopsy core, let's say, was only positive like in one area. It's still standard to treat the whole prostate, but there's some discussion for certain men in terms of like if you only have that area, let's say in the left base that's positive, that you could go in and basically ablate or just kill that area in the left base and then monitor like the rest of the prostate, but not treat the whole gland. The main idea behind that is that could you reduce someone's short and long-term side effects by only treating part of the gland, but kind of still win the game by controlling their PSA, right? And I think the biggest thing to try to save on is probably urinary changes, and then even bigger than that are long-term sexual dysfunction changes. Okay. So why are there so many different options? Like, why do we keep trying to find different ways of treating this? So part of it is it's a real estate problem. This is a tough spot to treat, okay? This is like a sideways view through a patient. So the patient's front is here, this is their back. We are trying to treat this little guy right in here. This is the prostate, but your bladder is right on top and in front, and your urethra, which carries the urine, runs right through it and then comes out the penis. And you've got the rectum right here in the back, right? So regardless of whether you want to go in and cut this out, so surgery has to cut here, and then reconnect these two together. Radiation has to, if you're doing external, the beam's got to come from outside and go in order to reach this. So that means you got to go through some rectum or some bladder. And brachytherapy is trying to treat you from inside out. But there's a lot in here, right? And there's a lot nearby. And so that's why this gets complicated and why, we have to think about kind of the side effects of what we can cause by what we do. So ultimately, the goal in terms of trying to educate patients is that we don't want you to have any treatment regret with whatever you choose to do, right? And this was a recent kind of study that was published this past year. that shows about 1 out of 10 men with localized prostate cancer do have some treatment-related regret at 5 years, right? And it seems like the strongest correlation regret is a mismatch of expectations versus reality in terms of kind of how effective was the treatment and what side effects they actually have. So the biggest goal of kind of today and trying to educate you guys is that we want you to understand like what are realistic expectations both in how successful the treatment will be and what side effects you may have in the short and long term. So defining the best, I would say this is like a big take home for me. It's going to depend. Best is going to be different for each person in this room in terms of what's important. And this is kind of a framework to think about kind of what are the things that go into best and why it's going to vary for each of you in this room. So when we think about it, there's a lot of things. So for some of you, you're going to say, I don't really care what happens to me. You give me the treatment that gives me the highest chance of this never coming back and making me live as long as possible. I don't care if that means I dribble. I don't care if that means I don't have sex. You do what you need to do, right? And others of you will be like, that's ridiculous. Like that makes no sense to me. I would be willing to accept a higher chance of maybe this coming back, but I would be really upset if I had incontinence the rest of my life. That, like, I play golf and I do this, and that's just like not going to work for me. So you have to think about different domains. One is kind of survival and disease control. One is kind of acute complications, what happens in the short term. And then ultimately, like I was saying, this is a disease where majority of people are going to live a really long time. And so you really need to think about these long-term things. And really what we're learning is that the best way to evaluate these long-term things is listening to the patient, right? So what we've learned is that if you come in and I write down then what you told me in terms of like how many urinary symptoms is this patient having, what's his sexual function, that as physicians we tend to underreport what our patients are really experiencing. And so there's been a big push to use what are called patient-reported outcomes. And many of you may be filling these out in your follow-ups, and we'll talk about this, where we give you a handout that says, I want you to fill this out based on what are your urinary symptoms and how are they bothering you, and your bowel symptoms and sexual. And so this is kind of where we'll look at in terms of what we'll look at in terms of the data trying to compare the different treatments, is looking at the patient-reported outcomes. So this is just a way of looking at like how do you put all of those different domains together, right? So this is what's called a radar plot. So this is basically looking at what we were just looking at, and 100 would mean that like you're perfect in every single one of these domains. So ideally, this red line would be on the outside of this circle for every single one of these things, right? We don't have a treatment that's like that, right? And that's just the reality. But for some patients, right, for this, let's say, example, sexual function was worse, let's say, for this treatment, you may be like, that's not what I want my circle to look like, right? I want my circle for this to be here, closer to perfect, and I would be willing to accept, something coming down like over here or something somewhere else. So that's why I think the best circle is going to be different for each man in this room. Okay. So let's kind of talk about two of these radiation treatment options, and kind of why they're so popular and where there's some of the controversy between them. Okay, so the first thing is kind of this graph here on the left. So what this is showing basically is that the dose of radiation that we deliver to the prostate is really important to the chances that we can control the cancer long term. Okay, so this is the dose that we give. Gray are the units of radiation. So this is the lowest dose and this is the higher dose. And this is you can think of it as a chance of having your prostate cancer controlled. Okay. These are trials that have been done over the past 20 years and even longer, where we used to only treat the prostate to about 60 gray. But as we've done trials and said, we think we need to go higher, we've seen improvements in the PSA control. Okay? But what we can do with brachytherapy or SBRT is we can now treat in this range where we're over like 90 gray, right? Where we didn't really have the technology to do that safely before, let's say 20 plus years ago. And the question is like, if you treat up in this range, can you improve outcomes for patients and can you do it safely, right? And what we've kind of learned here is that, this was from a recent study, is that as the dose got higher above 90 gray, so we're kind of in this range now, the chance of someone having a local failure in the prostate, meaning that where you radiated, there was basically no more prostate cancer, no local failure. Look how low that number gets as you get kind of above 90. You're kind of in that like 5% range, and then even when you get higher, it's almost perfect. Nothing's perfect, but almost, right? So there's a real motivation to be in this dose range, okay? And the two best techniques we have to get there are brachytherapy or SBRT. So now we're going to try to spend some time talking about, well, what are the pros and cons of using one or the other approach to get into this range? Yep.
Can these two therapies be used for recurrence after radical prostate?
Yep. So that is also an area of debate, but both can be used. So there's kind of growing data that the statement that is often used by surgeons, which is if you get radiation once, you can never get it again, it's actually not true. There is growing data that you can retreat the prostate after prior radiation. There are some increased risks, so it doesn't come with no risk. But there's debate in terms of if you're going to do that, should you do that with brachytherapy or SBRT? There's data to support both. I think there's greater data currently to support brachytherapy, but patients could get either one.
Sure.
Yeah.
I'm just a little confused. The advertisement come for here today. It's stated brachytherapy versus IMRT. That's not true. Is that right? Or is there SBRT and IMRT from the same source?
So the IMRT is kind of just referring to the technique that's being used to shape the dose. And so whether you get treatment over 4 to 5 weeks or 9 weeks or SBRT, you're basically using IMRT to kind of shape the dose. So the SBRT is really just kind of bringing how fast all the dose is being given, but the same principles kind of exist.
The same machine?
It's the same machine.
Okay, and one last question. SBRT, is that what is referred to as
CyberKnife is a machine that delivers kind of SBRT, but SBRT can be delivered on other platforms as well. So as we get into some of this discussion, I just want to give you some food for thought, okay? And we're going to come back to this. We are going to talk about mostly like a one-dose-fits-all paradigm, all right? We're going to talk about if you just had 1 core of Gleason 6 or you had 12 cores of Gleason 10, basically giving you the same dose and giving that same dose to the entire prostate. But it really doesn't make sense, right? We know that like there's different ways to cook a steak, but part of our problem is you can't slice the prostate in half and see whether it's cooked enough, right? You can do that on your barbecue, right? But that's the whole point of radiation, is that you don't cut anything, right? So we're going to talk about some of the limitations and kind of where we're at and kind of how this one dose fits all approach is probably not correct and how we're trying to make strides on that. So we're going to talk about SBRT first. So this is outside in. This is external beam radiation therapy. most commonly given as 5 treatments every other day. Most places will use some type of gold fiducial marker seeds that are either placed through the rectum or just through the skin between the scrotum and the anus, called the perineum. Some places always use like a hydrogel. The most common hydrogels are either Spacor or Barrigel currently. Then you'll get a CT planning session. Some places have MR planning, but most places are CT. Takes most places about a week to do the treatment planning, and then you come in for treatment, probably about 25 minutes each day, and done in about a week and a half. Okay. This is just an example of an external beam radiation machine. This is kind of what the fiducial marker seeds look like, just to give you a sense. These are tiny little gold marker seeds, about the size of like 3-4 millimeters. Usually this is just done in clinic with just some local anesthetic. We do them transperineal. This is kind of what the seed looks like on CT. Some places will do 3, some places will do 4. Okay. This is an example of a hydrogel placement. This is like a sideways view of the prostate. The idea is to place this gel here behind the prostate so that you push the rectum away, so that you try to limit radiation dose to the rectum. So, for example, this is an MRI where the prostate's right here. Here's the rectum, so you can see the front wall of the rectum sits very close to the back wall of the prostate. Here's what it looks like when the hydrogel is placed, this white here, so it pushed this wall of the rectum back away, so there's more space now between the back of the prostate and the front of the rectum, and then it will get absorbed by the body, usually over about 3 to 6 months. Okay. Here's just an example of a CT scanner. You come in, you're laying down on this table. There's usually some kind of like what's called a VAC-lock bag, which is kind of like a bean bag kind of around your hips or your thighs to kind of hold you so that you don't rotate around. And then you usually get 3 little tattoos at the end of that. Here's just an example of some of the planning that's done. So once you go home, you've left us with a 3-dimensional copy of yourself. And we have physicists and dosimetrists who help us figure out kind of what angles should the radiation beam come in so that we can focus the dose really just on the prostate and limit the dose to the bladder, rectum, and the bowel. When you come in for treatment each day, basically, we have your original anatomy, like when you came in for the planning, and then on the machine, there's like a CT that can be done before you get treated, right? So what we're doing is we oftentimes are making sure that the seeds that we put in the prostate align with what you look like on the day that you came, are there, right? And we're making sure your bladder is full, your rectum's not too empty. So there's a match that's done to make sure that you're exactly what you look like when we planned you, because that's what we're assuming you are to give you the treatment. So that's done first. Usually a physician is required to check that and sign off on that, and then the actual treatment would begin. So we're going to transition into brachytherapy. Brachytherapy, there are 2 types of brachytherapy. One is called low dose rate. Those are permanent seeds. So again, they're left permanently in the prostate. Think of them like batteries. They deliver their energy over weeks to months, and then they kind of die off. But they're left in the prostate, okay? And it's safe to do that. They're inert. They don't really cause any additional reactions because of that. And then high dose rate is basically virtual seeds. There's a little radiation source that's welded to the end of a cable, and that gets temporarily inserted into these little tubes that are directly inserted into the prostate. And then the radiation source comes out, and then the tubes come out, but you're not left with any permanent radiation in your prostate. So here are the logistics of it. So this is a minimally invasive process. I'm not a surgeon. There's no like cutting that's done, but it's something that we usually do in an operating room or a brachytherapy suite. Some places will do spinal anesthesia. Some places do general. Usually takes about an hour or two. With low dose rate, all the seeds are placed in the operating room. It's a one-time procedure. With HDR, if you're getting only brachytherapy, what we call monotherapy, it's 2 treatments. So those are spaced usually separately, 1 week or 2 weeks apart. But if you're getting it as a boost, meaning that it's being combined with external radiation, it's just usually 1 treatment. Okay. Here's just some pictures of low dose rate brachytherapy. Again, this is kind of what the seeds look like. Sometimes people will use loose seeds and sometimes they're stranded together. In the operating room, there's usually like a template here on the perineum where these tubes are basically inserted under ultrasound guidance in the rectum. Here's an example, just an x-ray of kind of what the seeds look like in the prostate. And then usually kind of while you're in the operating room, there are different ways to plan, but you kind of identify where the seeds were dropped in the prostate, and you can see what the distribution and your dose profile is going to look like while you're in the operating room, while you're implanting the patient.
You ever do it like focally, like where they just do it on a 3-4 instead of a 3-3 or something?
Meaning like just part of the prostate? Yep, that would just be part of doing focal therapy, and brachytherapy can be used for focal therapy. Yeah.
Approximately the number, I mean, I'm sure it varies, but the number of seeds that are put in there.
Yeah, it'll vary depending on the prostate size. So larger size, more seeds, but it can range from like somewhere in the 70s to over like 100. So it varies. Also depends on the type of seed you're using. Yep.
Say you have recurrence with the lymph node, can't do brachytherapy on the lymph node.
No, with exception, yeah, we usually would use external radiation to treat kind of a lymph node with exception. Yeah.
Can you repeat the question?
Yeah, it was a question of if you had an enlarged like lymph node, would you use brachytherapy for that? And I would say standardly the answer is no, because for brachytherapy you need to easily be able to get like a needle into that tissue so that you could get the source to go into it, or be able to drop the seeds directly into it. And most lymph nodes wouldn't really be that accessible to that, and it would be usually much more straightforward just to do external radiation. Here's the high dose rate example. So inside of this kind of machine here is like the cable and the radiation source. Here's kind of what the radiation source looks like, just welded to the end of this cable. Iridium 192 is the most common. And basically that cable will get pushed through kind of this tube directly into the tube that's in the patient. So the longer this source stays in any one position, the greater the dose that's deposited. So we use computer programming to help us figure out where should the source go and how long should it stay in any position. So here's like just a 3D example of like a prostate case where these parts of the tubes are sticking out from the patient. The tubes are basically implanted in the prostate here. And these red dots represent places where the radiation source could go. And the computer program helps us figure out like the source should stop here for 2 seconds, but skip this one and then stop here for 10 seconds. You realize there's an infinite number of combinations that could exist, which is why we need computer programming to help us figure that out. Mm-hmm.
Okay. Once you've had your prostate out and your PSA indicates there's still some crap out there, does brachytherapy, does that have any plan?
So the only context that okay, so the question was if you've had a prostatectomy and your PSA comes back, is there any role for brachytherapy? The only context that there may be is if during your evaluation they see that there's like a nodule that's recurred in the prostate bed. There are some places that will do the external radiation and then do brachytherapy as a boost, and other places will just do external radiation the whole way, but that would probably be the only context where it might be considered.
So when you're doing the brachytherapy, do you deliver a larger dose to where you know the lesions are?
Yeah, so some people do and some people don't. Oh, sorry. So the question was, do you kind of what's called dose paint, meaning like if there's an area where there's more cancer, do you give more compared to the rest of the gland? You can. It's pretty straightforward to do. Some places do and some people don't. It's not clear whether there's a real benefit in doing that, but you absolutely have the ability to if you want to. Yeah.
In regard to that same question, would the ability of dosing more in some areas
Maybe. So we're going to talk about dose. Oh, so the question is, if you dose painted, could it reduce potentially your side effects? And the answer is maybe, and we'll kind of talk about that a little bit more because that is a pretty active area of investigation that people are moving into. So here, the other logistical thing to think about with high dose rate brachytherapy, if you're receiving a consult about it, it can be done either with ultrasound-based planning or it can be done with CT-based or MRI-based, would be the same thing, based planning. Ultrasound planning, this needs to be done in a room that's kind of shielded, meaning that the room has to be able to allow the HDR source to go out and come back in. So you can't just do it in a regular operating room because the walls of a regular operating room aren't shielded enough to have radiation in them. But if a place has that, you basically go to sleep. All the catheters, are placed, and then all of the planning is done under ultrasound. So that can all happen kind of while you're still asleep. The treatment is given, the tubes come out, and you wake up done, basically. In a really efficient place, this can happen in about 2 hours. In a place that does it quite a bit. With CT-based planning, usually all of these tubes are being placed like in the operating room, but you can't be treated in the operating room. So when you wake up, you have this template on your perineum with the tube sticking out, but you haven't been treated yet. So you have to basically be transferred from the OR to wherever radiation oncology is to do a CT scan, and then they use the CT scan to plan your treatment. You get the treatment and then everything comes out. But because of the logistics of going from OR to CT scan to planning, takes more time. So usually takes more like 4 hours or 6 hours, depending on how efficient wherever you are can get you from OR to the next place to the next place. Yep.
With this radiation, are you in the room in a suit, or is this done with all mechanical?
Yeah, it's all what's called. So the question was, are we in the room when the radiation's being given? And the answer is no. It's all remotely delivered from this machine here. So we basically connect the ends of all the tubes. You can't really see it here, but there are multiple channels that can be put in here. So you can have, let's say, 18 or 20. So it would be multiple transfer tubes sticking out, and we would be out of the room, so only you would be in the room. But then this machine basically sends in the radiation source one channel at a time, but we're not in the room for that. Yes?
So going back to the ultrasound versus CT planning, are there any studies on patient outcomes that compare ultrasound versus CT?
Yeah, a great question. It appears the results are very similar between both. So, yeah. The question, sorry, I keep forgetting to do this. The question, any comparative outcomes really between ultrasound and CT-based planning? And the answer to that is I think the outcomes are similar between both.
Are both versions of within the script system?
So the question is, are both types of brachytherapy available in the Scripps system? I don't know the answer to that. I know that at UCSD, They predominantly were using low dose rate when John Eink was here, but he recently left, and perhaps in January when Dr. Munt is here, he can update you guys on the new faculty that's been recruited and what the plans are with the brachytherapy. So I'm not 100% sure, but I know Dr. Munt is coming, so he'll be able to answer that update for you.
Could you have somebody at Cedars-Sinai?
Yeah, I do them at Cedars. We only do high dose rate at Cedars. At UCLA, they're also all high dose rate. They do some low dose rate at City of Hope, as well as some high dose rate. But yeah, go ahead.
Maybe a little premature in your presentation. The PSA seems to be the all-inclusive, all-measuring, if you will, barometer for cancer going up, down, or sideways. My question is there anything new on the horizon to supplant the PSA count? Or we still hold stuck with PSA only?
Yeah, so the question is kind of currently PSA is really the gold standard biomarker for prostate cancer, and is there anything now or near horizon in terms of maybe supplanting that? We'll come to that in just a bit, so we'll come to that. Yep.
Depending on the facility where you need to see your patient anesthetic for period.
Yeah, so no. Typically, the patient would just. Oh, the question is if you're going to do CT-based planning, is the patient asleep the whole time? The answer is no. Typically, the patient will just be under anesthesia for the placement of the actual tubes. And then subsequently, they'll be awake the rest of the time. But usually, the patient will be given some local anesthetic around the prostate, like a periprostatic block, and typically the periprostatic block and a little bit more just IV pain medicine. They do fine for those few hours, but they're not asleep the rest of the time. Yes?
In regard to the high dose brachytherapy, back to
Yep. So the question is, if you're going to do high dose rate brachytherapy, can you do it as 2 treatments in one insertion as opposed to multiple? The answer is yes. There's variation in kind of how it's done. And so some places will do just one insertion, give one treatment that day, keep the gentleman overnight, which means you have the template still inside of you, which means you're still in bed, still mostly kind of flat, and then give the next treatment the next morning. Part of that is related to, there's differences. For example, if a patient is going to get a boost, meaning in combination with external beam, which is most commonly done for higher risk patients, there's some leeway in terms of kind of the standard dosing that can be done. So some places will just do one treatment for the boost, and some places still do 2. So places that do 1, it's not an issue, and places that do 2, they have to figure out do we keep them overnight or repeat it. But if you're going to do brachytherapy only with HDR, it needs to be 2 treatments. Unfortunately, we have randomized data now where groups have tried to do only 1 treatment, but unfortunately those men have had significantly higher chances of having their PSA come back compared to 2. So for now, HDR cannot reach, when used alone, cannot reach the same one and done as low dose rate. That was the goal, basically. So just a little bit of a background, when people started doing HDR only, this was kind of in the 90s, it started out closer to 6 treatments, and in Japan was closer to 9 treatments. And there's been this big push to be wow, that's a lot of time to keep a guy in bed with these tubes in. And really, over the last 20 plus years, the movement has been to go down in the number. So they got down to 4, they got down to 3, they got down to 2, and then there was great hope that it could get down to 1, but it doesn't look like that's going to work, at least in the way that it's been done. So the current standard, or the lowest number you can go right now, is 2, at least that I would say like standardly if you're not like on a clinical trial. Let me just keep going a little bit, sorry, and then we can come back to it. So this is like, we've gone through some of the logistics, so hopefully people feel comfortable understanding like what is the SBRT and what is the brachytherapy. I just want to spend a little bit of time just talking about, and coming back to this gentleman's question of like, well, what are the outcomes? What are the PSA control? What is the quality of life? And I think the way to think about this debate is like, is SBRT basically virtual HDR? Really, is it that we've gotten sophisticated enough in our ability to deliver external beam that you don't need to go to the operating room to have these tubes placed to go from inside out? You can accomplish the exact same things from outside in, right? So that's a good goal, right? I mean, we're all happy that if we have a heart attack, that someone doesn't have to crack open our chest anymore, but you can just have a catheter go through your groin to kind of manage things. And we're happy that if you get surgery, that it can be minimally invasive on a robot and not have to be, cut open. So advances of going from like invasive to non-invasive happen all over medicine. And the debate here is, have we accomplished that with SBRT compared to what we know has been tried and true with brachytherapy? So I'm going to focus on where probably the biggest benefit of brachytherapy and escalating the dose of the prostate has been seen. Okay, so this is a trial that was done on higher risk prostate cancer patients, and that's where we've kind of seen the biggest benefit of brachytherapy. This was a study that was done in Canada, where patients were randomized to get either only external radiation, or they got some external radiation and brachytherapy as a boost. The brachytherapy was low dose rate brachytherapy, and all the men got hormone treatment. Okay, so again, this is a higher risk patient population. And the red line represents the group that got the brachytherapy boost, and the black line is the group that got only external beam. And basically on this axis is time, and this axis is the chance that your PSA started going up again, basically. And what you can see is that for the first 5-ish years, the PSA control rates were about the same, right? Those two curves overlap. But as you keep going out with time, the brachytherapy curve that got the boost, it kind of flattens out. Those guys their PSA stays controlled. But the PSA control in the group that got external beam only continues to kind of slowly go down. Okay, so again, this is not in like low risk or favorable intermediate risk. This is like more in high risk patients. But when they look to see, hey, are the guys that had their PSA controlled better, are they living longer? These curves overlap. They lived about the same amount of time. And it's like, well, how does that work? And it's because this group of men that goes on to have a PSA failure still has a lot of treatment options. They still have a lot of things that they can go on to. And so they can ultimately still live the same amount of time, but they may be living now on active treatment, whereas this group here, they're good. They didn't need to get any more treatment. So one thing that is debated quite a bit is that some people argue that this benefit in PSA control, which is almost a 20% improvement, some people say that that's a soft endpoint, meaning that you haven't proven that someone lives longer because of this, and they say because of that, this is not valuable, and that this would only be valuable if you showed that they're living longer, right? So this is a big debate where some people are like, every guy should be offered this because of this benefit, and others are like, I don't think so. This doesn't make sense. So this is a big area of debate, okay? But what it's showing is that the dose escalation that's happening because of the brachytherapy is leading to improved PSA outcomes, okay? The other way of looking at this is that there, and this comes back to this gentleman's question a little bit. I'll answer just in a sec. Hold on. Are there early surrogates for like how a guy is ultimately going to do? And there's some data that if a guy's PSA gets to 0.2 or less within 4 years, there's a really high chance that they're going to be cured, right? And in the surgery literature, we often use this threshold of if your PSA is more than 0.2 in the surgery literature, sometimes they call that a failure. And so when they reanalyze this data using that definition of who had a PSA get to less than 0.2, you can still see that there's a massive difference in how many patients get their PSA that low if they get a brachytherapy boost compared to if they don't. And that's true in the intermediate risk patients or the high risk patients. So again, massive differences in chances of having a really low PSA, but still controversy over whether or not, every guy should get this or not. The other component of this controversy is this, is that in this study, there kind of was no free lunch, meaning that the dose was significantly escalated with the prostate brachytherapy. Again, this was low dose rate. But it came at a cost, meaning that more patients in the brachytherapy group had significant urinary side effects compared to the group that only got external radiation. So the chances that they got something that was significant within 5 years was almost 20% versus about 5%. So that's 1 in 5 guys having some significant urinary issue. But when they look to see like at 5 years, how many of them still had something, meaning like they could have gotten something, it got treated and it got better, it was closer to like 10% versus 2% at 5 years. So one of the arguments here is that yes, you saw a benefit, but it came at some cost. And is that cost worth it? And the other component here that people debate is that there were some criticisms of the brachytherapy technique that was used on this study, meaning that the patients that had the most urinary symptoms, when they went back to look at their brachytherapy plans, they noticed that a number of them had brachyseeds really low down in the prostate apex in the GU diaphragm, and that probably caused more urinary symptoms. So had that not happened, it's not as clear whether we would have seen this. But it's an important note that the technique matters and the experience of what's happening matters, and that these are technique-driven kind of outcomes. Yes?
Back to what you were saying before, and comparing the brachytherapy only versus the external beam. And you said the external beam patients were getting additional therapy. Were you talking about androgen deprivation?
Yeah, that would be the most common thing that they would go on to.
The brachytherapy, they would not get any.
Well, if they failed, they would, but less of them. Go back. There are patients in the brachytherapy arm that are failing, meaning having PSA failures, and they would then go down the same path as a patient who just had external beam. But the percentage of men who are having a failure is much less compared to the percentage of men that got external beam only. But then the pathways that they would end up on would be similar down the road.
Am I hearing that PSA as being the only biomarker for prostate cancer is really not that dependable?
It's actually a great marker. What happens, though, in these patients is that you lose it as a marker for a little while you're on hormone treatment, because it will drive your PSA down. So you don't really get to use it until you're off of the hormones and your testosterone recovers and then your PSA recovers. But it's a great marker. It's correct. But it's really good. It's a really good marker, and the advances that we have are more so like if the PSA goes up, we now have way better imaging tools to try to help us figure out where is that coming from. So even 5 years ago, we were mostly using just CT scan and bone scan, which is not really great at finding something when someone has a PSA of like 0.8 or 1 or something like that. But recently, kind of approved, we have like newer imaging modalities like PSMA, which is a PET scan specific for prostate cancer, that helps you find kind of where that rise is coming from in a way that we've never been able to before.
Aren't there so many variables to PSA that when we get them once every 4 or 6 months, they're really not that reliable?
No, they are very reliable, definitely. Certainly after treatment, they're definitely very reliable. There can be some more, I guess, confusion in how to interpret it, like when you're being screened for prostate cancer in terms of like, do I need a biopsy or not? But after you've been treated, it's really good.
So their variables don't matter. The fact that you can get different levels one time, 1 week after another.
You can get some variation, and after radiation, some patients will get something called a PSA bounce, where things start going up, and then you have to be patient and watch it go down. But after treatment, wouldn't it be typical for like your PSA just to be going up randomly without something else going on?
Is PSA a measurement of the cancer or the protein?
Well, it's a reflection of kind of the amount of cancer that's being kind of measured through that. It's not like a 1-to-1 that tells you exactly like what the volume of disease is there, but it gives you some estimation.
Isn't it a measurement of the protein that the cancer throws off?
Correct.
Okay.
Correct. So the question is like, well, can SBRT do the same thing, right? And we have some data for kind of the higher risk patients that if you just give SBRT, kind of what is happening to the prostate when you do that. This is a study from Memorial Sloan Kettering where they gave increasing doses of SBRT. So this is all just in 5 treatments. And these men were willing to get a biopsy 2 years after they had gotten their SBRT. And they asked the question of like, what were the chances that there were still like viable prostate cancer cells in the prostate 2 years after they had been treated, to use that kind of as a surrogate for did it work or do we think there's still something there? And what they found was that as they increased the dose, they found a lower number of positive biopsies, right? So showing that you kind of need to be in this dose range in order to have this number be about 10%. So the dose, again, we're seeing is important. You need to get a high enough dose. But as you start getting over 40 gray to the whole prostate, you again start running into the same issues that we do with brachytherapy, in that the toxicities start going up, whether that could be to the urethra, the bladder, or the rectum. Okay. So just to summarize a little bit, for the unfavorable intermediate or high-risk disease, I think currently, the strongest data for PSA control is with a brachytherapy boost, but there are some increased toxicities when we do that. It is technique dependent, and we'll talk about this in the quality of life of a low dose rate versus a high dose rate boost. SBRT only or as like a substitute as a boost for kind of unfavorable intermediate or high risk disease, it's accepted as standard by some, but I think it's actually, most people still think it needs more mature data. Depends on where you go, whether and what they think. But there are some increased toxicities as the dose gets above 40 gray. Kind of the area that people are moving is a little bit the opposite of what was suggested before, which is if you know that you need to give these higher doses to where the cancer is, can you give that high dose to those areas or give more, but then not give more to the rest of the prostate? And that's kind of this idea of micro boosting, meaning giving a small part of the prostate even more so that you can try to reduce the toxicity to the urethra, bladder, or the rectum. And there is kind of data now that, at least with this more of like the standard fractionation, that you can accomplish that without creating more toxicities, which is exciting. And now people are asking whether you can do that with SBRT, something called the hypoflame trial, which is basically trying to treat the whole prostate to one dose, but then small micro areas of the prostate to even higher doses. So this is kind of what this looks like. We've been doing this in brachytherapy a long time, and it's pretty straightforward. So here's the prostate, here's the rectum, and the idea is, can you take this whole prostate in blue to one dose, but then if the cancer is really here, and how would you know that? You have data from your MRI, you have data from your prostate biopsies to let you know where the cancer is. Could you give extra dose here even more? And by doing that, it would help you kind of limit how much more you give to the urethra, which is right there, and then how much you would give to the rectum. So the idea is, I don't have to give more dose to everything, but why don't I give a little bit more dose to just here? So this is pretty straightforward to do with brachytherapy. With SBRT, again, we talked about this hypoflame trial, which just recently reported in their abstract form with like 90 days of follow-up that in the short term it was safe. What did they do? They basically tried to treat the outer part of the prostate really just to 7 gray, but then they would allow parts of the prostate inside to get up to 10 gray, right? So meaning it's called an SIB, or a simultaneous integrated boost, meaning that in the same treatment, different parts of the prostate are getting treated to different doses. So you're still only going in 5 times, but instead of this whole prostate getting 7 gray, most of it gets 7 gray, but part of it gets 10 gray. Or at least that was the goal. And what they did is they said, try to get to 10, but if you're going to exceed the limits of the urethra or the rectum or the bladder, stop like when you reach that limit, because there are going to be some lesions that sit like right here, like right next to the rectum or right next to the urethra, and you just can't give that much dose. So on average, what they saw is that they could get the areas that they wanted to boost closer to about 45 gray, but not always up to 50. And that's just because of the proximity to some of the organs at risk. Okay. The story is a little bit different, I think, for low or favorable intermediate risk disease. Again, both SBRT and brachytherapy can deliver high doses to the prostate. When you use them alone, I think that they do have comparable PSA control and toxicities that go in the 5 to 10 year range, but we don't have randomized data. So we don't have like a randomized trial of half the men got SBRT, half of them got brachytherapy, and kind of what happened. This is mostly just looking at single institutions that have reported their outcomes. And at least in my opinion, most of the data here is in the 5 to 10 year range. It looks pretty similar. I think. The longest follow-up with high PSA control and low serious toxicities is with low dose rate brachytherapy, where there are multiple series that go out beyond 10 years and even beyond 15 years. And again, no really randomized comparisons between low dose rate and SBRT either. But I think that SBRT, when it is used, is more commonly used in this low and favorable intermediate risk population. Again, coming to this idea of early surrogates for long-term outcomes, and something that we will sometimes use is the chance of a patient, again, getting a PSA less than 0.2. So this was a large study that looked at patients who either got HDR only, low dose rate only, or SBRT. and they tried to see, again, this is not randomized, but just a retrospective review. They tried to see, like, if they looked at low-risk patients, intermediate-risk patients, or unfavorable, and this is favorable, what were the chances that they got a nadir under 0.2? These are what are called box whisker plots. So this line represents the median, or kind of where 50% are. The bottom and top of these boxes are quartiles. So it just shows you the range of kind of where people were. And you can see that, these nadirs get very low, kind of 0.1 with HDR, even a little bit lower with LDR. It's still under 0.2 with SBRT. And again, you still see them a little bit lower for low dose rate for the favorable intermediate, but with HDR and SBRT, they're both like around 0.2 and kind of similar in this unfavorable intermediate risk group. So all of these seem very encouraging to seem like they can get the PSA down to a pretty low level. The one thing I would point out, though, is that look at these box whisker plots. We try to tell everyone that, like, this is exactly how you will do, but look at the range that we see. The good thing about the range is that they're all still pretty low PSAs, kind of under 0.5, but it just goes to show you that the way that we stratify patients into these risk groups, it's not perfect. People do differently, even though we all put you, let's say, in this box of this risk group or this risk group. There's still variability kind of in how people do, and we're trying to move more towards trying to have kind of more of a better understanding of the biology that drives things. So I think more and more patients are getting additional testing like Decipher or Polaris to try to help us better understand things. So the last part, I know I'm keeping you guys a long time, is just talking about quality of life between these two. So again, when we're looking at outcomes, the most standard tool to use is the EPIC. So the EPIC is the Expanded Prostate Index Composite. This is the most standard patient-reported outcome tool that's used. It originally started as a 50-item questionnaire, but as you can imagine, that is exhausting for a patient to fill out every time they come in. It has been kind of shortened down into something that's just 16 questions that can get filled out within just a few minutes. It basically is designed to cover 5 different domains, 2 urinary, bowel, sexual, and then a vitality score. Okay. Just some comments on using the EPIC in terms of looking at quality of life. So this is the first randomized study comparing HDR versus LDR boost. We talked about the Ascend-RT trial having more urinary side effects. And the question is, if you used HDR instead of LDR, would it be different? So again, this was done by our Canadian colleagues. Basically, the main difference was whether they got an LDR or an HDR boost, but all of them got external radiation and hormones. And here's kind of how I would look at this. So I graphed this in this way. We're looking at basically just the urinary changes, okay? And we're looking at however you scored, and then you're at baseline, and then your change from baseline. So a negative means like you were doing worse, right? And a positive means you were doing better than when you first started. And there are 3 lines on here. The red is the HDR boost, the gray is the LDR boost, and the blue is if you had gotten external beam only kind of over 4 weeks based on the results from a study in the UK. So that wasn't an arm on this study. So I just added that as like a reference, like what if you had just gotten external radiation only. And I think the big take home here is that, all the treatments do cause a short-term decline in urinary symptoms. The decline is deeper with LDR compared to HDR, and the recovery with HDR is by about 6 months. But with LDR, you can see it's slower. closer to about a year or a year and a half. And the recovery with kind of just external only, it's a little bit faster than with HDR. So there are differences in the side effect profiles and the recovery of those toxicities depending on the type of treatment that you get. The same thing happened in the bowel domain. You can see that the external radiation only has a bigger decline in bowel domain than in urinary. There's a little bit bigger decline with the brachy boost, but there's a faster recovery now with the HDR, even compared to just the external radiation only, but the LDR takes longer to recover. So this is important data, I think, that I like sharing with patients, because this is what you guys told us. This is not what we told you. You reported to us, and so it's quite important. Mm-hmm.
Why do some people get insomnia after radiation treatment?
Question was, why do some patients get insomnia after radiation treatment? I don't know the answer to that. I don't know. I'm not sure. CHIP was the name of the study that was done in the UK that was trying to figure out whether it was safe to go from like 9 weeks down to 4 weeks. And so many people consider this like a standard arm treatment. If you were in Europe, you would get treated with 4 weeks. And some places here in the US, a lot of places do 4 weeks or 5.5. Kind of related to that, do we have any data about SBRT versus just the standard 9 weeks or closer to 4 or 5 weeks? And this was the first randomized study of SBRT versus kind of more standard treatment. This was published this year, so just to let you guys know, this is a rapidly evolving area that we're learning about each year. So these are patient-reported outcomes. So these are the urinary scores, and these are the bowel scores. So this is time here, and these are the proportion of patients. What I would focus on, so this is kind of the standard dosing, the CRT, and this is the SBRT. The thing I would focus on are the group reporting moderate to big problems. So you can see that at baseline, they're about the same. At 6 months, maybe a little bit more with SBRT. This is urinary symptoms. Maybe that's still persistent a little bit at 9 months, still maybe at 12 months. But by 24, they're pretty close. There are a little bit more urinary symptoms that are bothersome here, but they're pretty close. And you can look at like the no problems at 24 months. It's about 65%, maybe closer to about 50%. So a little bit different, but this is still pretty safe treatment. But there are a little bit more urinary symptoms that are happening when you finish all the treatment in just a week and a half. In terms of bowel stuff, like major issues, no real differences at baseline. Gets a little bit worse here at 6 months, kind of 9 months, but 12 months pretty much the same, and 24 months pretty much the same. So it looks like bowel-wise, things look pretty similar, but maybe a little bit more on the urinary bother side, kind of going a little bit faster. Mm-hmm. Yeah, so the most common would be like some type of like urgency type of feeling, or sometimes some looser stools. Like major issues like bleeding or something requiring like a procedure is like few percent. It's pretty rare. It's more kind of some changes in like daily bowel movements. Like sometimes you feel like certain foods, you feel like after you eat them, just kind of have to go to the bathroom quickly, or sometimes you feel like you have to have a bowel movement and you sit down, but you don't really need to, or sometimes a little bit like more gas or some feeling like that. And then kind of lastly here, we don't have randomized data between SBRT. Here it's just abbreviated as SABRE, is the same thing. Using HDR brachytherapy only, or HDR as a boost. This is some data from the Canadian group. That this group does all three of these techniques. and they tried to just retrospectively go back and look at like how are the patients doing. So all of these scores are EPIC scores, like we were talking about, patient-reported outcomes. You can see this only goes out to about 15 months. So it's short. This is not like 5-year kind of outcome. Again, these are rapidly evolving areas of research where we're all trying to figure out the answers to these questions, and we don't have all of them yet. But in terms of kind of, if you stay at 100, that means like you're perfect. So lower is worse. And you can see kind of the HDR mono maybe is a little bit better than SBRT, but not that different. But the boost patients have a little bit worse urinary outcomes. Bowel function, again, the HDR mono is a little bit higher, but I don't think there's like that much difference between these. These are kind of pretty similar to me. Irritative functions, again, SBRT and HDR right on top of each other, a little bit worse with the boost. And then sexual function, honestly, it's kind of a problem for all treatments, right? I don't think that the HDR being a little bit higher here is that meaningful. I think my take home from this is that there are some more toxicities when you use brachy as a boost compared to only doing brachy or only doing SBRT. And that's like my main take home from this. But the brachy and the SBRT, I think they look pretty similar, I think. So what's the best? I think it's going to depend on what's most important to you. I think they're both good options. They both have pros and cons. There are ongoing trials comparing SBRT to brachytherapy either alone or as a boost for unfavorable or high-risk patients. There are ongoing trials looking at SBRT versus brachytherapy as a salvage, meaning patients who have had prior radiation and need to get a second course. So there's a lot of unanswered questions. I'm hoping that today kind of provided some background that will be helpful in terms of thinking about these things. And just thank you for having me. We'll go from there.
Yeah, thank you, Doctor. That was that was a fantastic presentation. I've been coming to these meetings for up to 5 years, and I don't think that we've had as much of a brachytherapy specialist give so much information. I mean, there was certainly a lot of new information in that presentation that I did not know. Like I actually had always had that question, like, oh, with the low dose rate, do the seeds stay in? And yeah, great information there. I know there was a lot of questions during the presentation, but let's take a lot more now. One thing I will add is that if anyone's looking for the restrooms, they are out the back here down the hall to the left. So feel free to get up and use those. We all know we have to, including myself a few minutes ago. So let's start with a question here. And I'm going to bring the microphone around to everyone.
So just a question on, secondary malignancy rates with the different treatment modalities.
Yeah, so it's a great question. There's always been, in theory, that brachytherapy should have a lower second malignancy rate because the thought is that by going from inside out, you deliver less low dose to the surrounding tissues compared to the external that has to come from outside in. I don't know if that's actually ever been really proven, if that's actually true. Part of that is that secondary malignancies after radiation, thank goodness, while they happen, are relatively rare. And it's really hard to follow a population long enough to kind of see what happens, because it usually takes 10 or more years, and it would take thousands of patients to find this thing that happens 1% or less of the time. So in theory, it's supposed to be less, but I've never really seen anyone actually prove whether that's actually true.
This microphone, yeah. Hi, I had focal HDR brachytherapy at UCLA with Dr. Chang, And so I still have a large percentage of my prostate still intact. So at this point, I'm effectively active surveillance at this point. What would you suggest as far as the best way to monitor myself post focal HDR brachytherapy? And additional question, there's a lot of urinary and blood tests that are coming online that are helping to check for recurrence or risk factors and whether those might factor into active surveillance or ongoing monitoring.
Yeah, so it's an area that there's not a clear answer to. Again, the complexities become when you treat part of the gland, you don't expect to see the same naders that we've been seeing when you treat the whole gland. And related to the question before is that there can be more fluctuation in the PSAs when you still have your whole or part of the gland intact. We still use the same overall principles of looking at the nadir and then monitoring whether things rise from the nadir. I think the data that's probably the strongest in the focal setting, beyond using our standard definitions, is looking at the PSA velocity and kind of how quickly it's kind of going up. What it does, though, is it kind of creates a situation where you have to have a pretty low threshold to get probably like a multi-parametric MRI if you're concerned about a rising PSA. Usually we'll have a pretty low bar to do that, and that can help you identify whether or not there's anything going on either where you treated or outside in the rest of the prostate.
Doctor, I concur with Aaron and everybody else in this room. You get a 10 out of 10. You're the best. Yeah.
Well, thank you.
My question is regarding PSA, going back to earlier. I was cruising along nicely at 0.06, jumped to 3, then jumped to 12, went in for a whole bunch of radiation, drove it down a little bit to 0.9. That's pretty dramatic. And one of the comments that came back was, well, maybe it's an aberration in the PSA testing system. And that was my previous question. Is there any other sidecar items, is there any other way of monitoring prostate cancer up and down other than PSA?
Not that I would say is standard right now after treatment. I think imaging has been very helpful, like PSMA, to help try to better identify things, but it still remains the most standard and tried to true. I think the area that a lot of people have some excitement in, but still not really ready for prime time, is something called like circulating tumor kind of DNA or liquid biopsies. The idea being that tumors can shed cells or parts of the cells into our bloodstream, and that there are technologies now that allow us to find these very small amounts of potentially tumor. And not only that, but they can sequence like the information that they can extract from it, which is remarkable because it's like a super small amount, and we never thought we could find it or do anything with it. And people are now asking, like, should we be monitoring with liquid biopsies? Can that give you additional or supplementary information? But that's still mostly on kind of study at this time. But I think we will get there very soon, but PSA is still gold standard.
And I think one of those tests is made by a company called Grail. Is that right?
Grail does something like that, and there are a bunch of different companies, but Grail does something similar like that.
Gotcha. Yeah. Pardon me. Yeah, I was. Funny you should mention that, because this time around with open enrollment for me at work, our work now tries to push everybody into the Scripps network, and Scripps is actually advertising, offering that test to people that sign up for our premier, healthcare plan at work.
Yeah, my understanding is that companies mostly focus on trying to make an early diagnosis by trying to find something, and I think that's where their like original validation was of their technology.
Gotcha. More questions?
Yeah, I've had prostate cancer for over 11 years now, and thank God for this group. I didn't have a prostatectomy at that time. At this point, I'm looking at brachytherapy, and my question is the genomic testing, and this would be kind of a point for some of the new people here. I found that so encouraging when I got the genomic testing, but there was some question about how valid is it. Can you comment on the validity of genomic testing at this point?
Yeah, so there are a number of different platforms that can be used. The platform that has the greatest validity, especially after radiation, is the Decipher test. And that is just because the company basically partnered with what's called the NRG. The NRG basically is like a national group a cooperative group that basically runs like major clinical trials, let's say for prostate cancer across the United States. So Decipher was able to partner with NRG to reanalyze like a lot of their radiation data from their trials. And the reason that that's so valuable is that many of the NRG studies have like 10 years of follow-up or longer. And so you can really, and those men were on study, so they were all treated the same way and they got kind of followed the same way. And so you really then get to try to validate those markers against like real long-term outcomes. And they've done that on a number of different trials, and it's been very promising, so much so that there are actually 2 currently open NRG trials now that are actually stratifying men based on their Decipher score in terms of whether we should treat them more intensely or less intensely. So for the unfavorable intermediate risk patients, if you have a low Decipher score, you can get randomized either to radiation plus 6 months of hormones, which is standard, or just radiation and no hormones, right? So if that ends up being positive, that's a huge win for men, right? I mean, for that percentage that's low risk, if you can be like, you don't benefit from the hormones, because right now we kind of have like a one size fits all. You're unfavorable intermediate, you really should get the hormones and do the radiation, but there's no guy that really wants to be on 6 months of hormones. And then the flip is if you're like a high Decipher, there's a question of like, is, let's say, just Lupron alone enough, or do you need Lupron plus something else? And then similarly, that is being used for high-risk patients to stratify the duration of hormones, that maybe instead of being on 18 or 24 months, maybe you could only be on 12 months if you're a lower risk. So it's being integrated into what we do. There's still a number of unanswered questions, but I think that is the most validated tool, and so much so that it's actually being tested now prospectively on a couple NRG national trials.
So would a genomic test from 5 years ago be just as good as one today?
I don't know if the scores from Decipher have changed over that time period. I don't know if they like continuously update their proprietary algorithm that comes up with a score. So I'm not sure. It was a good question to ask them if like your score from 5 years ago would be the same today, or have they modified based on additional stuff that they know? I don't know. That's a great question.
I think in regards to that, one thing that I recall from one of the presentations a couple of years ago was to ask your oncologist to, I guess, either review or resubmit the same sequencing that was done, just to see if there were new genes that have been identified since then that then might help decide, oh, that means, this was the cause, or, this might be a different treatment option, more beneficial, such as what you're saying with this current analysis. I doubt that the Decipher score or any other genetic testing would help in making a decision between brachytherapy and SBRT, though, right? Just too subtle of a difference in the treatment.
No, I mean, there's definitely no data on that, but I don't think that it would help. It's more helpful from a standpoint of thinking about should hormones be added or should it not, or is it reasonable to do one of them without external radiation or treating the pelvic lymph nodes, or should you treat them?
You're just saying 6 months of androgen deprivation. Why not more?
For the unfavorable intermediate risk, we know that 4 to 6 months is appropriate, but for the higher risk patients, we typically do more. So it depends what risk group.
How much more is the limit?
So there's definitely controversy on that. I think the lowest that people usually give, especially if they're using a brachytherapy boost, is 12 months. But it can range from 12 months to 36 months.
Thank you. Excellent job.
Yeah, thanks.
The question is that if someone had already had surgery and also salvage radiation and hormone therapy, and the PSA is coming back but not gone out of sight. So the sample is all gone because it's 12, 13 years ago. So does it make any sense to still do genetic study, but there's no tissues from the prostate to be getting it done? So what would be a way of remedying that?
I think eventually people will be able to do more with the liquid biopsies and to get more information. They'll kind of look in the blood and be like, hey, we found some cells in there and we're able to analyze them and this is what's going on. So my guess is that will happen soon, actually not that long from now, but it's not like standard like today. There are a lot of people doing it on study, but I think that that's probably where we will get.
All right. How many more questions do we have? Okay, we're just going to take your 3 questions and then we're going to wrap up here.
Thank you. This was an excellent presentation, and I know that it was focused on those of us who still have their prostate. Now, for those who don't have their prostate any longer, and you're talking about years later when there is recurrence, talking about the technique of dealing with lymph nodes or other parts of the body that show a prostate cancer. One of the techniques is the protonics. Can you make a comment about the existing tools today to deal with that?
Yeah. So my brief comment on protons, and you'll hear, I'm sure, a different perspective, is there was kind of this thought that protons would have significantly less kind of side effects based on the way the dose is deposited compared to photons. I'm not really aware that there's really any good data that has really panned out. There was recently a randomized controlled trial of protons versus photons for definitive prostate that was recently completed. So very soon we'll have a real answer to that. But I'm not really aware of data that we have is so convincing that protons are that much better. The technologies have gotten so much better with both techniques. We aren't really, thank goodness, like seeing lots of like major rectal problems term. So if someone wants to get it, I think it's fine. I personally, in my own practice, I don't like insist that it happens, but if somebody wants it, I think it's fine. But I don't tell patients like you really should go and do this. I just don't feel like the data supports that, but it is a controversial area.
My question is, what is the percentage of high-dose radiation versus the old seed implants being done currently in your field?
Yeah, so we didn't get into this because it tends to lead into politics a little bit, which I try to stay out of. The number of men actually getting brachytherapy in the United States is very small. Part of it is related to the number of practitioners that can do it is small. Overall, I would say the number of men getting LDR versus HDR, there are more men getting HDR than LDR. And of the patients getting brachytherapy, most of them are getting it as a boost as opposed to using it alone. And one of the reasons that more do HDR is because the side effect profile is a little bit gentler in terms of the urinary side effects in the short term and the recovery of bowel side effects. But either one is totally appropriate, but there's definitely a bigger shift towards HDR because of the control. But the number of people doing it is small. And that's just a training problem. It's a reimbursement problem. And so I'll stop there before I get too political about it.
I actually have kind of a two-part question, and I'll try to make it short. The statistics that you showed on your slides, are the treatments initial treatments, or does that take into consideration recurrence? And the second part is, if you have recurrence, is one favorable above the other?
Yep. So mostly, we really just focused on definitive treatment first time around. In the second time around, there's a lot of controversy over what is best. There was a recent study trying to summarize like all of the literature out there, and suggest that like brachytherapy has like the lowest kind of potential impact on urinary and bowel function. And there is kind of prospective data with brachytherapy. But even the brachytherapy data shows that when we do it, there's still a chance that we don't control everything. And the doses that most people have been using with SBRT are lower than that. So I personally, and I'm totally biased about it, I personally prefer brachytherapy for retreatment because the general principle for me is you're trying to re-expose the least amount of normal tissue possible in order to limit the risk of any damage. And going from inside out helps you accomplish that better than outside in, and it allows you to get the highest dose possible. So for me, until there's more like mature data either way, I usually don't, in my practice, offer SBRT for re-irradiation and just offer brachytherapy. But there are plenty of people that do offer SBRT, and both are within reason, but those are the reasons that I don't.
All right, great questions today. We're going to wrap it up so that we can give a chance to everybody to answer some, strike up a conversation with someone, come up and ask us more questions, have some refreshments outside. This video will be available on the DVDs that you can buy starting from the next meeting, as well as on YouTube. So we encourage you to share those with others. And last note is please no food or drink brought back into the auditorium. Just keep all of that outside, and we'll pretty much all be moving out there. And I think that's about it. One more round of applause for a fantastic presentation.